So peripheral artery disease. So why do we care about peripheral artery disease? So again, if you ask, an interventionalist, they might show you a picture like this. Look at that terrible narrowing. And this is actually why a lot of patients show up to clinic. They say, I've got an 80% blockage of my artery. I got a test, and there are these common tests out there marketed to the public to say, look for blockages in your arteries. And they come in and they say, I've got 80% or whatever it is. And a lot of people have stuff like this. So this doesn't worry me. And this is the other thing that you commonly see is pain could be a symptom of peripheral artery disease. And this is a picture that I found on the internet from another healthcare facility depicting pain in the legs from peripheral artery disease. Can anyone tell me why this is a bad picture for peripheral artery disease pain? So where would you expect patients to have pain if they... The calves would be the classic place for claudication pain, right? Because the problem with peripheral artery disease is not getting enough blood there, and with claudication, it's when you're exercising. So good, he's out for a walk, he's in his gym shorts, but he's clutching his knee, which is not a place where you have a lot of muscles that need blood flow during exercise. And no offense to the orthopedists in the audience, but there are a lot of causes of pain in the legs, and this is a lot of what I do is I just get people who come and see me and say, I've got pain in my legs, and there are 100 reasons why this could be. They've got spinal stenosis, they've got hip problem, they've got a knee problem, they've got flat feet, they've got all these kinds of things. And when they have pain when they walk, we often, or I see them as possible claudicants, but I think that really that is a very small subset of people who have pain when they walk. But that said, say this guy had claudication, it's still not something that is not the thing that matters most to me. For a lot of people who have claudication, this can be very bothersome, and we try to treat their pain, but people who have only pain when they walk are very unlikely to progress to things like having wounds on their feet, to having black toes, to having amputations. And so they have disease of the arteries throughout their body. They're at risk of heart attacks and strokes, and there are good reasons to manage them medically, but I really try not to intervene on people who have pain in their calves when they walk, unless it's sort of the classic picture of someone who can't go about their very basic daily activities. The mailman who can't walk his route, the person who can't play with their grandkids because they can't do 10 steps in the house. At some point, claudication becomes disabling, but once we start intervening on patients with claudication, we can tend to make them worse. So what I really care about is patients who have problems like this. Patients with gangrene on their feet, patients with wounds on their feet that won't heal, patients who've had previous surgeries that may not be healing well. This picture from Podiatry Today has somebody who you see is missing their left leg and only has a part of their right leg. So preventing amputation is the thing that I care most about for peripheral artery disease patients, and the time when I think we should intervene urgently. So we would ideally like to catch people before they get to the black toes, when they just have a little tip of their toe that has an ulcer, or they have pain at rest that means that they're having significant ischemia even when they're not walking. That's sort of a precursor to developing gangrene. So I would like to catch those people early and prevent amputation. So this slide will look very similar to a previous one. Causes of peripheral artery disease include hypertension, hyperlipidemia, diabetes, kidney failure and dialysis. Causes disease of the peripheral arteries, it's a little different than the plaque inside the arteries. It tends to cause the wall of the arteries to become calcified and hard, and that can cause some funny things like the ankle brachial index that you may know as a way to measure blood flow to the legs can get thrown off because these arteries are so hard you can't even blow up a blood pressure cuff on their legs. And that same process causes the arteries to also be narrowed and difficult to operate on, unfortunately. But both diabetes and kidney failure can contribute to that. Age, again, smoking, again, is the number one risk factor, the number one thing we can work on. And again, same sorts of things for, in terms of management for these patients. The one thing I didn't put on a previous slide because I think the evidence isn't quite as good, but certainly for patients with peripheral artery disease in their legs, the American Heart Association guidelines say that people who have peripheral artery disease should be considered to have had a previous MI in terms of their risk of cardiac disease. So anyone with peripheral artery disease should be on a high dose of a statin, regardless of what their cholesterol numbers are. And so this is a fine point, but it's something that I try to encourage our residents and our nurse practitioners and things to catch is somebody comes in on 10 milligrams of simvastatin for their peripheral artery disease treatment. Ideally, they should be on 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin, a high dose. And so when I catch those people who come in that just have this baby dose of a statin because maybe they had an adverse reaction in the past, maybe their lipid numbers weren't that bad, and so their primary care doctor thought, well, they're under control with just 10. Those are patients that, again, we can catch these things in the perioperative setting. Well, why is this person only on 5 milligrams of simvastatin? And all the other things are the same. Aspirin and Plavix, the other thing I would say about that with respect to peripheral artery disease is that in particular we care about those in patients who have either some complex reconstruction and multiple failed interventions and things like that, or people who have pre-existing stents. So just like coronary stents, we tend to add Plavix for patients who've had peripheral artery stents. But all of them should be on aspirin unless they're on something more aggressive. Okay, so in terms of evaluating a baseline for a peripheral artery disease patient, as I said, there are a bunch of reasons why people might have this off, both related to their PAD and related to their other comorbidities. So their motor function is not something that should change significantly in chronic atherosclerosis of the legs. But if these people are elderly, bedbound because of pain, bad back pain, bad knee pain, things like that, they may not have good motor function. Same with sensation or diabetes control may contribute to a neuropathy in the legs. They may have neuropathy related to spinal stenosis, etc. And so motor and sensory functions are things that we look for mostly in acute changes. Somebody who just suddenly occluded a bypass graft or had an embolus from their heart or something, then we think that is going to tend to affect motor and sensory function, and it's an emergency to potentially fix something. So if you were to notice that somebody lost motor function that they previously had, that would potentially be an emergency. So knowing sort of where they're starting is very important. And examining pulses, I think is an art near and dear to my heart. Having a good pulse exam, again, I think is more than just having a Doppler signal in the feet. And I would encourage you to think about the difference between a Doppler signal and a pulse. My mentors told me that you can get a Doppler signal if you get 2 red cells and you move them at 1 centimeter a second. Just anything moving past this Doppler probe. And often that's what we're sort of reassuring ourselves with, is these couple little sounds on the Doppler probe. But that's very different than having a palpable pulse, where you've generated a blood pressure in that artery. And so if someone has a pulse that you're sure is theirs and not yours, because we've all felt our own pulse in somebody's foot, then that is much more reassuring and much more meaningful than someone having a Doppler signal. And somebody who previously had a palpable pulse, who now only has a Doppler signal, is someone who has clinically gotten worse and might have thrombosed a graft or something. So I encourage people to start at the feet. If somebody has palpable dorsalis pedis and posterior tibial pulses, they could have an occluded artery up here. There are people who have long-term iliac occlusions and have such amazing collaterals that they have palpable pulses in their feet, but that's pretty rare and probably not something that changes a lot of management in the inpatient setting. But if you start at the feet and you feel good pulses, great, you can probably stop. But if you don't feel a good pulse there, then I would encourage you to keep working proximally until you get to a place where you can feel it. The DP in the foot comes down from the anterior tibial artery, runs between these two metatarsal bones between the first two toes. And so if you're feeling for the DP, it's usually just lateral to the first extensor tendon, so like here. And what I usually recommend is that whether you're feeling for it or listening with a Doppler, if you start medially and then just move laterally, you're going to cross it at some point. So you don't have to be moving around in 2 dimensions. You just have to move in 1 dimension, and you shouldn't miss it if you move slowly. Same thing for the, there's a nice picture with the extensor tendon. And for the posterior tibial artery, it's just posterior to the medial malleolus, which is here. So if you were to start at the medial malleolus and work posteriorly, then the same thing should work for finding the posterior tibial artery, because there's no way it's going to be under the bone here. So if you start at the bone and work backwards, then you'll pass it. And if it's not palpable, then keep working up the leg. The popliteal pulse is probably something that's mostly just for your edification to practice feeling the popliteal pulse, because a lot of people can have difficulty feeling that depending on body habitus and things like that. But then the femoral pulse. So if you don't feel a pedal pulse, I would encourage you to at least check for a femoral pulse, because if they've lost a femoral pulse also, that is very different in terms of where in the body the problem is than if they still have a femoral pulse but they don't have a pedal pulse. And then once you know what's palpable, they've got a femoral pulse, they don't have a pedal pulse, then go check the other things with a Doppler. They've got a pedal Doppler signal is different. Even though the Doppler signal is not as good as a pulse, having a Doppler signal is better than not having a Doppler signal. Okay. In terms of catching changes in these patients, we always recommend regular neurovascular exams. So mostly that means checking their pulses, their Doppler signals, but it also does mean motor and sensory function. So as I said, losing that could be an acute sign of a change. And remember that this applies to the leg that had the intervention, but may also apply to other extremities. We may have done an angiogram from the left leg to treat the right leg. We may even have done an angiogram from the arm to treat both legs. And so they may have a sheath still stuck in some artery somewhere. And so in addition to the leg that has the gangrenous toe or whatever, don't forget to check the other affected extremities. And then in terms of catching changes, also remember that they all have coronary disease. Whether they know it, whether it says it in their chart or not, they all have coronary disease. And so if they have changes on their telemetry, if they suddenly have new chest pain, if their blood pressure is wonky, these are people that have a low threshold for thinking this person might be having an MI, this person might be having some other new AFib, etc. Okay. I think this is what I just said, that remember that in endovascular procedures we can kind of get to lots of places from lots of other places. So it's typically the contralateral groin that we access to treat a leg, but it could be lots of other places, so be sure to ask about that. And then evaluating for hematoma is different than evaluating for ecchymosis, and so remember that hematoma is really the sort of palpable swelling, or that's how I think about it. The hematoma is sort of a mass, as opposed to the discoloration that is the bruise, the ecchymosis. And so this certainly, I think everyone would recognize as a hematoma in the groin, but usually they don't look like this. And this is another picture I found online of a palpable hard mass in the right groin. And I don't know about you, but I can't see much of anything on this picture. And off what this, I think, drives home is, I love pictures. If you send me a picture, take a picture into the patient's chart of somebody's toe or their wound or whatever, I love that. It really helps me in managing their care. But when somebody sends me a picture of a groin that might have a hematoma, it really doesn't help me at all. Either I have to be there and put my hands on it, or rely on one of you who has done this a lot to feel it and feel, is this the same as it was before or not? Some people have lumpy, bumpy groins, and they had a mass there from before, or whatever. They've got a big lymph node, or not. And is this really a new change? Did they come out of the operating room with some swelling there or not? And so, as part of your initial assessment and your repeat exams, I would say anybody who has either an endovascular procedure with a puncture site or an open procedure, that you should physically put your hands on that area and know what it feels like. And there may be a role for something like marking the size of hematoma or something, but mostly feeling it is the thing that matters most to me. And then brief word about how to hold pressure. This, I think, is a great skill from vascular surgery that can be applied to lots of other things. And I think the key lesson that I tell medical students is, when you're in the operating room and we have bleeding in the operating room from a hole in a blood vessel, the best instrument sometimes to control it is just a single finger on the hole. A single finger on the hole can have a vessel be totally hemostatic and no bleeding, or tiny little pickups holding the hole or something. And theoretically, if you have just one hole from a needle in an artery, it's like you've just put in an IV and taken it out, right? Just pressure from one finger over that site should be enough to stop bleeding, even from pretty big procedures that we do in the groin. But you can't see where the hole in the artery is when you haven't opened it up. So the difference between where the needle goes into the skin, say the head is over that way and the foot's down this way, it goes into the skin here, but the hole in the artery is right here. So one finger right here could be enough to control bleeding there, and that's really where you want to hold pressure. But since we don't know exactly where that is, I usually tell people to put a couple of fingers, with one finger around where the skin puncture is, so that you get maybe a little above the hole, at the hole, a little below the hole, etc. And this picture also shows why intervening early when somebody might have a tiny little hematoma is so much better than waiting until they have a big hematoma. Because if you have something like this and there's a little bit of blood coming out here, and either maybe it's coming out the skin or maybe it's just accumulating here, a little pressure, gets that tissue to go right up against the hole, and the bleeding can stop. Great. But what happens when you have a bunch of blood that's built up here? When you put pressure right over the hole in the artery, you're just putting pressure over this big ball of hematoma. And then you're relying on this squishy mass of partly congealed blood to occlude that hole, which is much less good than the soft tissue doing it. So trying to hold pressure when you have something like this, or like that previous picture of that big purple groin, is much harder, or maybe impossible, to really get the bleeding to stop with just direct pressure. both legs. And some references. I think that might be my last slide. I don't know how I'm doing on time, but if I'm not too late.
You're doing
I'll take
good,
questions.
you're doing good. Questions?
At West, are you planning, I should introduce myself, I'm Janae, the stroke coordinator.
Hi, Jeanette.
Hello. At West, are you planning, I know we're planning on doing more carotid and arterectomies, but we currently don't do stenting here, correct?
As far as I know, none has yet been done here.
Are we planning?
I don't think that there is the question I have that maybe you can help me answer is to what degree we have neurointerventional resources here.
We don't have any, so.
And my guess would be that that would be the concern of most of our vascular surgeons with doing that. In theory, it's not necessarily any more likely to have a problem with a carotid stent than with an endarterectomy, and so I don't see why we couldn't do carotid stenting here. And I'll discuss it with my partners, but it's not a technically complicated procedure, and so I think once we have a good staff that's familiar with the endovascular stuff, because we're currently sort of training staff that the staff for the cath lab is separate from the cath for the operating room, and so we need folks in the operating room who are familiar with catheters and wires and things like that. I think once we have that going regularly, we could do that here.
Do you guys have any other questions?